legislators, they're going to be receptive to this. So I can walk around, right, and meander as I tend to do. So I'm going to talk about clinical practice guidelines, which are they've been around for a while, but they're really gaining importance, and we see it right in the APTA strategic plan. First point in the APTA strategic plan that we're under right now is that we need to increase effectiveness of care. If we look at objective B, increase practitioner use of and adherence to best practice guidelines. So the APTA has seen this, and I hope I will make the case this evening about the value of these clinical practice guidelines and why the APTA has moved in this direction. And before that the APTA is also working to increase the number of clinical practice guidelines that are out there addressing, informing, and supporting physical therapist practice. When I put this together, my wife looked at my presentation and she said, no, this isn't any good. It needs pictures. And so I then decided, well, if it needs pictures, there'll be pictures of her. I don't think she approves of that, but this is my wife and I racing canoes, which is what I do for fun. And I'm going to use that also as my framework for the discussion. This is the start of a race course that we were on, and we're going to see if we can use that to guide us down to the finish line. So if we're going to talk about clinical practice guidelines, the big resource is the National Guideline Clearinghouse, which is a database of clinical practice guidelines. It's a publicly accessible resource that's managed and run through the Agency for Healthcare Research and Quality. And any of us can go there and search, as well as patients who are interested in finding out about care options. If you go to the National Guideline Clearinghouse, this is what it looks like, and it allows you to access clinical practice guidelines. These clinical practice guidelines are documents that have been developed through a systematic review of the literature. So what they've done is each team that does a clinical practice guideline will describe the process they use and systematically review, first search and then review all of the literature on a given topic. Documented within the guidelines, they will tell you how they went about that search, and they'll also tell you that the guidelines are developed with input from all stakeholders. So if we look at physical therapy guidelines, they will be input from physicians with an interest in this. There'll also be input from consumer groups because they have a stakeholder in this. Patient groups, reimbursement agencies are involved in this process of developing clinical practice guidelines. These are kept as current documents in the National Guideline Clearinghouse. If they have not been revised after 5 years, they're removed from there. So in summary, the guidelines that are in the clearinghouse are scientifically valid. They are strategically accounting for bias. Anytime we do a review, there's the potential for bias, but because of their systematic process, they do try and account for that by describing the process they've used to minimize any influence of bias. They should be up to date, and I've found they're trustworthy. So now that I'm advocating for guidelines, how do we find out about them? How do we work our way through this process? And those poles are hanging on a race course because as we maneuver a canoe through, we have to go between the poles. If you touch the poles, there's a penalty. If you miss them, there's a bigger penalty in this racing. So, as an example, I went into the clearinghouse and put in physical therapy. It returned 967 clinical practice guidelines that had something about physical therapy in them. And it gives you some examples of what you might find in here. Diagnosis and treatment of low back pain. Spasticity in children and young people with non-progressive brain disorders. evidence-based care guideline for conservative management of leg calf herpes disease. So there's a wide breadth of information available in clinical practice guidelines. It won't cover everything because part of the limitation of clinical practice guidelines is that you need to have sufficient evidence to inform the conclusions. And in many areas we don't yet. But with a systematic review, if we have it, they're going to tease that out. What I'll use for a framework tonight is I'd like to talk about the use of clinical practice guidelines from some different examples. An example of individual physical therapists and how we might use it to inform our practices and patient management, as well as how we might use it among teams of healthcare providers. For example, across an institution so that we coordinate and organize our care, and also by teams of healthcare providers across systems so that we improve the healthcare we're providing. So for the first example, I'd like to look at a clinical practice guideline that was developed by the orthopedic section of the APTA on shoulder pain and mobility deficits, and consider how this may be informative in clinical practice. If you go into this clinical practice guideline, what you would find is descriptions of the clinical course that is typically seen with adhesive capsulitis, as well as information about the diagnosis and the differential diagnosis that accompanies this, the tests and measures that should be used in the examination, and strategies for intervention. So by accessing that guideline, you gain that information, which fits very well in our model of patient-client management, because as we look at the steps that we'll need to manage, they've done a very nice job, and this is not surprising because it was primarily developed by physical therapists. They've done a nice job of addressing those components of patient management. For the examples I want to give this evening, I am going to talk about the interventions that are addressed in the guideline. And in the guideline, this is a limited, not a full list of the interventions that they've addressed. And for example, in reviewing the literature, they found that intra-articular corticosteroid injections combined with mobility interventions and stretching will provide short-term pain relief and improve function. And what you will see with any of the guidelines is they then also evaluate the strength of that recommendation based on the literature they were able to review, and they found that this recommendation is based on strong evidence. Again, this is going to be a limited description of interventions for adhesive capsulitis, but they've also described the benefits of shortwave diathermy, ultrasound, or electrical stimulation combined with mobility and stretching exercises as an intervention for adhesive capsulitis and shoulder pain, with a recommendation, although at this one, the recommendation is based on weak evidence. Joint mobilization, primarily directed at the glenohumeral joint, is supported with a recommendation that this also, at this stage, has weak evidence, but sufficient evidence to make it a recommendation. And stretching exercises is recommended with moderate evidence that clinicians should instruct patients in stretching exercises. The intensity should be determined by the individual patient's response. That's what I forgot to bring up earlier. If you have any questions about what I'm presenting, please ask them as I go along. I don't really have a set process for this, and when questions come up, wave at me and I'll see if I can answer them. So I'm making my way down the course here. Questions or discussion at this point? Dr. White. Sure. He asked how they gauge the difference between weak evidence, moderate evidence, and strong evidence. And there's actually about 5 or 6 different models for doing that right now. And the group that's developing the clinical practice guideline typically is going to choose the one that best fits their needs. one of the things we find is that traditional medical models for determining effectiveness are based on, we get a lot of money to determine how well this pharmacological agent works, and it's very easy in that case. We're going to give 1,000 patients a placebo and 1,000 patients that medication, and we can do a nice randomized, blinded study to determine the effect. Well, that doesn't work well for so many of the things we do in physical therapy and in other parts of healthcare, such as surgery, such as prevention and wellness interventions. So depending on the type of clinical practice guideline that's being developed, there may be a different tool that is used to weigh that evidence. And part of what they need to do in developing the clinical practice guideline is to justify the tool that they've chosen. So you'll find it different with each one. Even today, the ones I present, there will be some different descriptors depending on how they've gone about it. That help? I'll see if I make some more sense of it as I go along. So what I would like to do now is borrow heavily from an article that was in the Journal of Orthopedic and Sports Physical Therapy last year, because they laid this out very nicely. This was an editorial that tried to address some of the resistance that we currently have to the use of clinical practice guidelines, because there's some concern by clinicians that this will tell me what I need to do, and where does that leave my judgment? And they proposed, and I agree, that this is a misunderstanding of how guidelines are used. One of the things we want to do with clinical guidelines is be very considerate of where they will fit into our practice of physical therapy. And I like this analogy that they provide here. Clinical guidelines can be considered from the perspective of altitude. And if we look from the 30,000-foot perspective, we're going to be able to use clinical practice guidelines to describe boundaries around what types of tests and measures we should use in our examination, boundaries on what types of interventions we should be using in our interventions. Excuse me. And it's also going to tell us if something's not addressed in the guideline, we should be very considerate about the lack of evidence and possibly reevaluate our use of that test or measure or that intervention. Because there needs to be treatment variation, there's another perspective that's equivalent to the 15,000-foot perspective as we come down in altitude. And at that altitude, we really need to look at individual studies that best inform us about our individual or unique patient needs that are going to vary from patient to patient. So, excuse me. In those patients, we should be considering the clinical practice guidelines, but also looking at those studies that go beyond the larger perspective of a population and best address unique characteristics among patients. And then as we continue with that analogy, as we get down to ground level, we're going to need to perform interventions, choose techniques, adjust dosing based on our clinical reasoning around individual patients. The clinical practice guidelines aren't designed to inform that and aren't going to be a substitute for good clinical reasoning. There's really a value in that for effective practice in physical therapy. To add to that, I want to bring up the most recent Macmillan lecture. For the students who aren't familiar with it, the Macmillan lecture is the highest honor provided by the American Physical Therapy Association. The lectureship is announced at the annual conference each year, which has now become NEXT. So the next conference will be in June of 2014, and we will hear the next Macmillan lecture there. But in the In the Macmillan lecture that was provided this year by Roger Nelson, one of the things he cautioned us is that payment systems will require a focus on the value delivered from treatment. Payment systems will no longer reimburse for services for which no proof of efficacy is reported. Value-based payments will demand transparency in outcome reports. The efficacy of specific treatments will be constantly updated with feedback to monitor the effectiveness or value of treatment. And this is really what the APTA has anticipated, and why APTA has been moving towards the use of the promotion of clinical practice guidelines is because we expect that more and more reimbursement agencies are going to hold us accountable for the evidence. They have a lot of data about what it is we're billing for with our patients. And so they're now going to become more reliant on comparing, this is the primary diagnosis, this is what was billed for that, and they don't fit. So there's some urgency in the APTA to grow clinical practice guidelines that do provide a well-supported, systematic process that justifies what we do. Questions so far? Again, if you have them, let me know. Another example that I wanted to provide was how we may be able to improve coordination among the members of the healthcare team with the use of clinical practice guidelines. And the example I want to use is the management of early rheumatoid arthritis, which is available in the National Guideline Clearinghouse. And what I did with this one is I followed through the guideline and pulled out some points for consideration. And what they describe in this guideline is that rheumatoid arthritis is best managed by a multidisciplinary team. So they justify in this description the role of the rheumatologist as well as the role of a dietitian, a pharmacist, or, because it was written in Scotland, a physiotherapist. And that's important information if we are trying to collaborate with healthcare providers who may not be appreciating and using us in the management of someone with rheumatoid arthritis. They go on in this guideline to provide information that I find very helpful, very informative for my management of patients with rheumatoid arthritis. They describe that early initiation and treatment with disease-modifying anti-rheumatic drugs is recommended to control the symptoms and signs of rheumatoid arthritis, as well as limiting the progression of the disease, as is evident radiographically. So if I'm providing services and I don't have a good understanding of these disease-modifying anti-rheumatic drugs, I'll find out about them on a future slide in this presentation, but in the clinical practice guideline, so that I appreciate why my patients are taking a medication with sometimes serious side effects, but also with rather significant benefits to it. They also tell me, so that I can coordinate and complement my messages with those of the other members of the healthcare team, that analgesics in rheumatoid arthritis should only be used as an adjunct to the nonsteroidal anti-inflammatory drugs and the disease-modifying anti-rheumatic drug therapy. These nonsteroidal anti-inflammatory drugs provide relief of pain and stiffness, but they do not arrest or slow the progression of the rheumatoid arthritis. They do this by inhibiting cyclooxygenase, and there's no evidence for a difference in the effectiveness of nonsteroidal anti-inflammatory drugs. When we look specifically at the disease-modifying anti-rheumatic drugs, methotrexate, and I went and practiced this one, now I'm going to stumble, sulfasalazine are the drugs of choice because they tend to have lesser toxicity or less problematic toxicity profiles, and they tend to have good effective treatment. So these drugs should be used in early rheumatoid arthritis. Many of us may have encountered patients who are saying, you know, they told me to take this, but I'm having the side effects. Do I really need to take it? Do you think I should be? Why can't I just do exercises and change my diet? And it's helpful for me when I'm not reading lots of literature about pharmacological management for rheumatoid arthritis to have access to a clinical practice guideline that tells me this is the preferred path. And then they go on to describe that rather than trying one disease-modifying drug, and then if that's not working well, trying another sequentially, it's really better that that the patients should be participating in combination therapies. So rather than stop one and try a new one, the preferred treatment path is to start one and then add another one to that in order to gain the optimal response. So when my patients have questions, it's much easier for me to understand the rheumatologist's perspective and to support that as patients are working with them. And then, as they also describe in here, they justify the role for physical therapy in rheumatoid arthritis, because you may find that there are providers in the community who say, no, 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 that is going, rheumatoid arthritis is going to have a devastating effect on joint surfaces, tendons are weakened, muscle weakness, you need to rest and take these medications. As they describe here, physical therapy management is effective, and it should be prescribed to overcome adverse effects such as reductions in muscle strength, improving endurance, improving aerobic capacity, that there should be dynamic exercise. Just a few years ago, we avoided vigorous exercise. There should be dynamic exercises to increase aerobic capacity, to increase muscle strength. There's no adverse effects on the disease activity or pain are observed with these interventions. There's limited evidence indicating that specific strength training programs can reduce impairments. Nice, succinct justification for our contributions for someone with rheumatoid arthritis. Questions for me? All right. Now, as you look for this information, you will find clinical practice guidelines in the National Guideline Database, and what you will find there is a narrower report. And if you decide you want more information, the original documents are a great resource to help you find out a little more about the clinical practice guidelines, such as rheumatoid arthritis. So one of the resources that's available, as you scroll down through the guideline, down near the bottom, they'll tell you that the guideline availability, and then you can get access to the original full document because it's a condensed version that's available online, and that is available free through a link that's provided right there. And then there's companion documents. Companion documents, I'll come up with some examples later, but become very important because some organizations are saying, well, we've put this together for clinicians, but should there be a patient education component? Oh, we're going to put the companion document that's written for patients, not for clinicians, up there so patients can access those. And you can use those because they're in the public domain for patient education resources. So there'll be a number of things that may support or complement your understanding of that topic by scrolling down and looking at the availability of companion documents. But, yes, Bob? It is at www.guideline.gov. and it'll be in the presentation, and I think these are available, and if not, I'll email them to anyone who asks for them, so you can click on it because I've got the link right in there. But yeah, it's off of the Agency for Healthcare Research and Quality's website, and if I can make a pitch, when you get a chance, go poke around on AHRQ's site. There's lots of great resources in there. For example, they have a morbidity or mortality rounds. Comes out every month. It's typically 3 cases that they look through and they analyze. And there's some really nice literature available through there and other resources. I see a hand going up in the back. The clinical, he asked if the companion documents were available for all clinical practice guidelines, and the link will be there for almost all of them. Some journal articles, because before these get reviewed by AHRQ, they have to be published in a journal. Most journals are trying to put those in the public domain right away, so generally that's available, but sometimes they may not be. Now here's a great example of how we may want to use clinical practice guidelines to educate other members of the healthcare team and persuade them about optimal patient management strategies. Can you hear me okay in the back? My voice is cracking a little bit, and I don't know how much this is picking me up, but and in this case, I used an example that helps clarify the role of what we do in physical therapy. This is a recent guideline on physical therapy management of congenital muscular torticollis. It's an evidence-based clinical practice guideline that was developed by the pediatric section of the APTA. And again, I'm going to borrow directly from the clinical practice guideline because they did a nice job with it, Sandra Kaplan and the group there. Congenital muscular torticollis is fairly common. We're going to see it in up to 2% of newborns. So that's, at a frequent enough rate that pediatric therapists and other healthcare providers for children are going to encounter this somewhat regularly. It's going to be a postural deformity of the neck, evident at or soon after birth. And this gets important because if we can initiate treatment for this congenital torticollis, if we initiate it before the age of 1 month, 98% of those children are going to achieve near normal range of motion within 1.5 months. Nice and quick. However, after the age of 1 month, but before the age of 6 months, if we start treatment after 1 month, the intervention is going to take about 6 months to achieve an optimal outcome. And if treatment isn't started until after 6 months, it's going to take 9 to 10 months of treatment before we achieve their optimal outcome, and they are less likely to have a good outcome. So that's very worrisome because if it's identified early, we have much better outcomes for these children. So the first thing I think about with this is I go back to my patient-client management and say, well, this is important for my prognosis. The clinical practice guideline is going to tell me as a physical therapist, or as a discussion we had recently in class, as a novice who's trying to have a good handle on prognosis, it's going to tell me what that prognosis should be, not depending on a lot of my test and measure results, but really based upon the age at which the interventions are started. But more importantly, excuse me, what we can do is use this information to also help other members of the healthcare team appreciate how important it is for early recognition and initiation of treatment for someone who has, for a child with congenital muscular torticollis. And this was important because what they found is that the American Academy of Pediatrics, their standard screening does not recommend looking for torticollis until the age of 2 months. That at a newborn, they're looking for head dysmorphia. At 1 week, they're supposed to screen for skull deformities, but it's not till that child is 2 months old that torticollis is part of the standard screen, which is well beyond the best time to initiate treatment. So one of the action statements that came out of this clinical practice guideline is that newborns should be screened for risk for congenital muscular torticollis by any healthcare provider, by physicians, by nurse practitioners, by physical therapists. This screening should be done, and what they need to do is look for the presence of neck or facial or cranial asymmetry that's going to be evident in the first couple days after birth. You can look for that with performance of passive range of motion for cervical rotation and lateral flexion, and it's visually evident. And based on the evidence they had, there was strong support for doing that. They found that it is readily evident, but not yet routine care to look at that young age. And then they were also able to support with moderate strength the recommendation that as soon as that's identified, the infant should be referred to their physician and to a physical therapist. So this should become the standard of practice, and as soon as it's identified that there is a positional preference or a reduction in cervical range of motion, that they should begin physical therapy interventions. And the nice thing with the clinical practice guideline is, say, wow, I'm real interested in this. How do I use this to manage my patients? They have a nice algorithm that's available in the guideline that says, here's the preferred path. So those people who want to use this to provide recommendations to colleagues, this is a great tool with strong evidence to moderate evidence justifying these recommendations. Questions? This one's not my wife. It's my son, also racing the same course. He did better than she did. The boys like to compare their times tandem with me to mom's times tandem with me, and they like to rub it in when they have faster times. Bob.
Care that high quality medical practices for various types of closed joint, back surgery, transplant, and target. And what they did to research throughout the country with facilities that provide the best care with all complications, and I'm going to say, and then also consider finances for that, and read through all of the people that are in the Walmart healthcare system, that if they go to that facility, there's no copay, and they pay for the transportation that people are telling them to go. And the question was, whether they go for cheaper, and it didn't work. That outcome, because the complications they go cost more money than providing the quality care in the first place. And they take places like Johns Hopkins, Kaiser Permanente, and places that demonstrate outstanding healthcare outcomes. And this is probably, without the physical therapist, going to be also key intervention to something because of this therapist and great outcomes, you're going to be able to go there. And so maybe the whole case is top down, maybe some of the others. So your presentation is very timely right now, so how about the young practitioners? And all the others have really
So to summarize for the people who couldn't hear that, because I'm on the microphone, one of the young practitioners here was describing NPR summarized a change in Walmart's strategies for health insurance that is very similar, I'll add to this a bit, to what we heard about at the Innovation Summit that the APTA hosted in the spring of 2013. More and more, we're seeing large employers are not going to insurance agents, insurance companies and saying, give us a bid. They're going and saying, this is what we want. And some of these large companies are saying, we're losing a lot to musculoskeletal disorders. We expect a physical therapist to be the first point of contact. Not will you. They're saying this is what we expect because where we're losing money is the time they're not working. We're paying a lot for health care, but we're also losing the workers. So if you can show me the data that you're going to have them back on the floor, that's what's going to drive their contracts. And I went off on a tangent, but which doesn't surprise my students. But what he also described was that they weren't necessarily looking for the lowest bid. Rather, they were looking at other measures of quality, because if we can reduce complications, as an example, then we reduce the cost. That's also what we see the federal government trying to do when we look at accountable care organizations and bundling of reimbursement around diagnoses, because part of the Affordable Care Act includes bundling. Bundling is a set fee for the hospitalization and a window of time for 30 to 60 days outside of that. And this is the type of evidence that will better position us to negotiate, especially if we're a smaller practice, to say, look, I'm on top of these clinical practice guidelines. This is the process we follow, and we can show you some quality outcomes as well. So I hope that this is timely, and that's why I'm excited about what clinical practice guidelines can inform for our practices. Let's move away from Eric. And then my favorite one is, as healthcare is getting more complex, we really manage our outcomes through systems. And you know that. And you'd say, all right, I'm providing physical therapy for someone who's had a knee arthroplasty, a shoulder repair, but it's really a system of care that's interdependent upon the quality of the surgery that was provided, the quality of the pain management that's managed pharmacologically, the quality of the physical therapy. Systems of care becomes more and more important. And to me, what I get excited about, based around acute care physical therapy, is what's going on in intensive care units. We now know that, I'm getting ahead of my slide, so I'm going to start by talking about the clinical practice guideline for management of pain, agitation, and delirium in adult patients in the intensive care unit. This was about a 3-year process that developed through the Society for Critical Care Medicine. They published this clinical practice guideline, and because it's very important to them to change practices across systems, they also have published a number of companion documents to inform the implementation of this clinical practice guideline. And so I was involved with one of those, recent article on implementation of the pain, agitation, and delirium clinical practice guidelines and promoting patient mobility to prevent post-intensive care syndrome. So they're saying, all right, we're going to give you a clinical practice guideline, and we're going to give you accompanying documents to implement it across systems, because when we look at intensive care units, we're talking about the collaboration of surgeons, various types of physicians, nurses, respiratory therapists, dietitians, pharmacists, physical therapists. This is something we're seeing in our literature a lot. For example, Physical Therapy Journal recently did a 2-issue series on critical illness, gave us a lot of good information. What we're learning is that it's safe, and interventions in the intensive care unit are effective at reducing the impairments and preserving functioning in people who are in the ICU. So the Society for Critical Care Medicine has developed both the clinical practice guideline and supporting resources. Just want to point out That's Darren Trees, a physical therapist in Texas, exercising a patient on the Movio, which is his design. He built the first one in his garage with his dad, and now he has that out, and pretty soon he's going to have a bed with a similar capacity coming out for patients in the intensive care units. So, in the clinical practice guideline, they concluded that performing early mobilization of ICU patients whenever it's feasible will reduce the incidence and the duration of delirium. And the problem with delirium is we know that delirium is not responsive to any interventions. There are not medications that can resolve delirium. It is responsive to prevention, but the only effective prevention that we have evidence for is early mobilization. When we prevent delirium, we have shorter stays in the ICU, we have less psycho-emotional distress. When we have shorter stays in the ICU, we see shorter stays in the hospital, shorter time on the ventilator, and we save money. So mobilization found striking reductions in the incidence of delirium in the hospital length of stay and in the ICU length of stay, with an increase in ventilator-free days. This suggests that early and aggressive mobilization is unlikely to harm these patients, but may reduce the incidence and duration of delirium, shorten the ICU and hospital length of stay, and lower hospital costs. That's what hospitals are all about these days, so that's pretty good. What they've done to help interpret these is in the guidelines. They've set up tables that are nice, quick reference sources. They really intend for these to be posted around units so that people can refer to them. And, for example, if we're looking at delirium, the prevention is very clear: reduce the use of benzodiazepines. Best care, just a few years ago, was benzodiazepines, because we reduced recall, we reduced cognitive functioning, we reduced the metabolic demands of a body by inducing this coma. Now we're saying no. While we had that as a common practice, we have no evidence to support that. Rather, the recommendation in the bottom right-hand corner box is mobilize and exercise patients early. And the other thing they did was said, all right, if we're going to make these recommendations, we're also going to recommend quality measures that we think are important for intensive care units. And look what they did for physical therapy. They recommended, and there were no physical therapists on the development of this clinical practice guideline, they recommended that a quality measure should be the percentage of patients receiving daily physical therapy and early mobility. Great. The challenge is we can't do that alone in an ICU, because for that to happen, we can't have patients sedated. Oh, well, what they're also recommending is sleep regimens for patients. They're recommending reducing sedation and periods of awakeness every day, and that's actually having a big impact on reducing some of the cognitive and psychiatric morbidity that accompanies a stay in the intensive care unit. That means we need to change practices among anesthesiologists, respiratory therapists, nurses. So it has to be a system-wide change to make this happen. Just being an enthusiastic, well-informed physical therapist with this clinical practice guideline isn't going to change the medication regimens in an intensive care unit. That's where a tool like this allows us to have that dialogue across systems and have the evidence to support that discussion. And then I'm going to read this one because this is the one I was able to write and describe. This is a tool that's designed to support that clinical practice guideline. And the Pain, Agitation, Delirium Clinical Practice Guidelines recommend the mobilization of patients in the intensive care unit when feasible to reduce incidence and duration of delirium to improve functional outcomes. Achieving within intensive care unit mobilization requires collaboration among many members of the healthcare team and acceptance of a culture of mobility among the team of providers. Creating a new culture of mobility in an ICU requires a deliberate and comprehensive effort to engage the stakeholders, the physicians, nurses, respiratory therapists, PTs, and others, and benefits from relying on a protocol to guide patient management. So then if we follow that tool, we see, oh, well, if we need to, if we're going to work on reducing sedation and accelerating extubation, is there a strategy to do that? And yes, there is. I want this one in the presentation simply because I had to pay $190 for copyright for this so that we can put it in the article. But this is really directed at respiratory therapists. This is really directed at anesthesiologists and pulmonologists so that they change their strategies so that we can implement the appropriate physical therapy. And then also in that tool, if you're a physical therapist saying, wait a minute, I don't treat patients in the intensive care unit, they're too sick. So, well, there's an algorithm for that decision making as well. And so if you go to this tool, you can say, here's the algorithm that is provided to inform the physical therapist, or for the physicians who are real nervous about me as a physical therapist going in there, say, no, this is an algorithm. Take a look at it and let me know if there's any part you don't agree with. But this is accepted evidence for best practice around the patient in the intensive care unit. Questions so far from my ramblings? You can tell which one I got excited most about. Brittany.
Yeah, you're certainly making a great argument for the benefit of guidelines. But is there a concern or risk that is following guidelines may sway from or the individualized care that becomes the concept of therapy?
I'm going to come back to this slide and go to another. I'm going to borrow from Childs et al. Because they did a nice job. Another criticism we've heard from guidelines is they limit the individual physical therapist's autonomy. We believe that medical practice requires a commitment to best practice over individual practice. It's interesting to note that in the areas of medicine with higher risk of death and poor decision-making, for example, anesthesiology or cardiology, guidelines are more prevalent. Guidelines have improved care and saved lives in these areas largely because the collective knowledge better informs an individual provider. We do not believe that anesthesiologists and cardiologists lack autonomy for using guidelines. So their argument is that, again, we take that altitude perspective. Clinical practice guidelines are going to be helpful at the 30,000 foot, helpful at the 15,000 foot perspective. But when you're in the room with the patient at ground level, they don't allow you to customize to that individual. And so I think they're more informative to a practice that is wondering why they're not getting referrals for some patients, and they can go look at the guidelines and see if they want to change their practices. They're informative to an institution that is trying to coordinate care amongst groups so you understand and collaborate across groups, but I don't think it's going to change, for example, how I'm going to engage this particular patient in consideration of how inflamed is that structure right now. Is she acute or chronic? What's the pain management then and a willingness to move? And that really is where we can customize and meet their needs.
And I'll just add to that, I think I guess you can look at it as we're fortunate in physical therapy is that we often don't have good data about exactly this is the correct intervention. A lot of times clinical practice guidelines will say exercise is what you should be doing with these patients. And it doesn't necessarily say we know it is this exact exercise at this intensity and this number of times a week. So there's still a lot of playroom in there to use, and hopefully you're being informed by basic science and whatever clinical evidence we have. But a lot of times that's limited. So there's still a lot of wiggle room. Like I say, manual therapy is really good for these, but exactly which technique, exactly for how long, what direction, all that stuff is we just don't know. And I think that's not a good thing necessarily, because it'd be nice to have a better idea about what to get the odds in our favor of taking the right direction at the right amount. But we don't have it now. There's still a lot of room.
And if you couldn't hear that, I'm sorry, because it was a great and pithy response. I think the description for rheumatoid arthritis is a great example. It validates the role for physical therapy and for fitness aerobic type exercises as well as moderate impact exercises, but it doesn't tell me what they're going to be. But it does open the door for the discussion with the provider, the physician who's not comfortable, not referring to me because he or she is resistant to that type of exercise. Ryan.
Are they going to take away from physicians performing research, or are they going to rely heavily on these guidelines? Really performing research like that? I feel like in 5 to 10 years, it's even more apparent that
So the question was, will these guidelines take away the need for and the value from research about what we're doing? And I think we are so far away from having the evidence for many of these things that I'm not worried about that. And the guidelines are designed to be a fluid and changing interpretation of that evidence. That's why the Guideline Clearinghouse requires that they be reviewed every 5 years. If it hasn't been reviewed in 5 years, they pull it from the Guideline Clearinghouse until it is reviewed, which is actually another avenue of research for people who want to. We've got our basic scientists who are generating new knowledge, but there's translational research, and this is an example of taking that evidence because a systematic review, typically these are searching the first time round, they're returning 2,000 to 4,000 hits of relevant articles. They superficially review those, and then you'll see the guidelines are typically developed around 2 dozen, 3 dozen, 4 dozen articles that actually provided the type of information they needed. We still need that, and I think we're going to have a growing understanding. A classic area would be surgery. So much of our surgery, one of the examples behind why the APTA has been concerned is we don't have good evidence, if I understand correctly, that physical therapy has a significant benefit following joint arthroplasty. We're treating these patients. We routinely are involved, but now we're getting challenged about why. And if you look at the literature around surgery, it's all unique to one approach or another. It's comparing two approaches. We don't have good evidence around the sequela after the surgery. And so there's a push to try and coalesce some of that information into a guideline that will help us clarify and justify the role for working with patients after joint arthroplasty. So I think, if anything, it's clarifying where we don't have the evidence, and there's going to need to be more research. So if I've piqued your interest enough that you want to find out, go to the National Guideline Clearinghouse. You can access that for free. When you see your first guideline, and my students recently went through this with me, you're going to see a documentation of all the methods they use to search the literature, all the methods they used for evaluating the literature, how they determine strength or weakness of a recommendation, and it is a rather protracted read. I think it's worth doing it the first couple times so you get a handle on guidelines. After that, they have a jump to function, and you're typically going to want to either jump to the recommendations or jump to the benefits and harms of implementing a guideline. So if you look at the guideline for management of early rheumatoid arthritis, which goes on for pages and pages about the scope and the methodology and qualifying statements that really you say, all right, is there anything in here or not? Then you get down several pages and you see recommendations. Once you're familiar with the layout, then you use the jump to function. Hit recommendations, it brings you right there. And if you find you really like the recommendations and you want to understand them so you can advocate to the physicians in your area, then you can go look at the accompanying documents. If you find you really disagree with some of them, then you can go look at their scope and their methods to see if it was valid and appropriate. But the first few times through, there's a lot of information that's not as inspiring. I see some students nodding. Did I get that correct? Questions about that? Good, my voice is holding up. This is me at a race up in Canada 4 years ago. As I described earlier, you will find that you can use the guidelines that are searchable online to find the supporting documents to better inform your analysis and your decisions. We've already seen this slide, and I hope it was helpful. And then if you really get excited about this stuff and are real geeky about it, you can subscribe to a weekly email. So every week I get an update of which new guidelines have been accepted or posted on AHRQ. I also, being geeky about this, can get updates on weekly updates on quality measures that have been endorsed and monthly updates on morbidity and mortality rounds. And that brings me to the finish line, which is just visible at the distance as I'm showing in a race here in Canada. So, other questions, considerations, thoughts about clinical practice guidelines? Jesse?
The documents for the original document, curriculum, it's not going to bring you to the journal publishing. Correct.
The question was, would any of this bring you to the journal in which it was published? So if you go to the guideline on early rheumatoid arthritis and click on that link on the far right for the Scottish Intercollegiate Guidelines Network, it brings you directly to the original article, which is a free download. So yes, you should, they, as much as possible, have made these accessible. Other comments or questions about clinical practice guidelines? And I've roamed through some various areas because I thought it might make it most interesting. I hope you have thoughts about how that will fit into your practice. There's pediatric, there's geriatric, there's medical, there's surgical. There is a developing understanding of these. Right now, there are about 10 or 12 that have been written by physical therapy groups, and there are probably another 25 or so under development. The orthopedic section really was out in front on this, and they've become a great resource to the other sections on how to do this. So if you're a subscriber to the Journal of Orthopedic and Sports Physical Therapy, you've seen these. They are not light documents, 35 to 50 pages typically, and you have to sift through them to find the parts that you want, but they need to justify their strategy and process by being elaborate about it. But now we're seeing them used more pediatrics, neurology, and others. And so we're trying to move those forward as quickly as we can. The other thing that may fit with and complement this is if people have not seen PT Now is an APTA member benefit that at this point has 8 clinical summaries, but it's a different tool that's really designed to help the physical therapist with the management of patients based around evidence. And it's not a clinical practice guideline process because, again, there aren't enough clinical practice guidelines out there, but it's trying to reduce that unwarranted variation in practice and refine so we use the tests and measures that best fit to a patient or group. So if you go there and look up Parkinson's disease or Achilles tendonitis, there's some nice guidelines, not clinical practice guidelines, but guidelines for care for physical therapists. Hand came up, Shauna. I don't have a sense. I know that I've encountered practice guidelines from the American Occupational Therapy Association. I know I've encountered a number of them that are driven by nursing groups. But I don't, a lot of times I'll use a guideline and not pay enough attention to who actually originated it, because it's a comprehensive process. I'm in the early stages now of leading a group to develop a clinical practice guideline on post-intensive care syndrome. Our stakeholders are intensive care unit physicians, intensive care unit nurses. Our stakeholders, there's a advocacy group for people with what's the acute respiratory distress syndrome. So they have a stake in this. We're going to have a representative from them participate in the process. So while we'll have 3 physical therapists lead it, another group of about 15 will be participating in the evaluation of the literature, and while we'll primarily write the guideline, they will be editing and reviewing, so there's not about physical therapists telling physicians what should happen to reduce post-intensive care syndrome, or telling nurse practitioners what they should be looking for a year after someone's left in ICU. It's really so that it's a collaborative effort to inform the continuum of care and the continuum of services, so we will get input from all of them. Most guidelines are going to be written that way. I hope it was informative, and I'm going to turn the meeting back over to you as well. Thank you.